Okay, just gonna go straight ahead. Look, spine surgery has evolved, and you can see open TLIF, MI TLIF, endoscopic TLIF, MI surgery is now clearly probably the new gold standard. But there is an untouched frontier for MIs. We've done discectomy, spinocerebellar listhesis, cervical radiculopathy, fractures, all MIs. But there's one pathology that really hasn't addressed it well. That's adult spinal deformity. But why is that so? In a survey by the SRS, by Neil Anand, looking at all these deformity guys, right? 70% would do open surgery, 23% would do hybrid surgery, but only 7% of all the deformity gurus would do MIS. And why is that so? Possibly because of the technical challenges. In MIS deformity, it is, imagine your wound is covered up, difficult to line up the screws, put in the rod, get the correct rod contour for alignment, decompression, multiple levels, painful, osteotomies, ponties, get a nice fusion bit, and what about radiation? So of course, if you can see, it makes everything so much easier. And of course, not just the technical challenges, but also the surgical goals must be met, not only about MIS principles, but also the deformity principles. So imagine so much things you have to do just to do CMIS fusion. And I'll tell you it's not easy, but these are some of the strategies that have helped me, and by no means am I Neil Anand is the leading expert in this, but I'll tell you some of these things have really helped me. 5 things: OLIF, patient selection, robotic screws, your reduction towers, and unit rods. These are the 5 things that I think really made me have the confidence to do more. First, OLIF. We spoke about this for the last 3 sessions. Now, if you just want to put percutaneous screws, your construct will fail because there's no fusion. So what do you need? You need an anterior fusion, and that's where OLIF comes in. And once you have an anterior fusion, then you can put percutaneous screws at the back and do CMIS fusion. But OLIF isn't the only good thing about fusion, is that there's excellent fusion, but also, in addition, there's good indirect decompression. And when there's indirect decompression, that means you do not have to open up the back because you don't have to do a laminectomy. So you can put everything MIS. It's also got good coronal correction. And you can see releasing the osteophytes like this. It's got good sagittal correction and multi-level correction as well. Imagine doing a 4-level TLIF. The patient's going to get a flat back. Next, patient selection. Now, we talked about this and our previous speakers covered this. I think beware of these cases. Large curves, osteoporosis, and a rigid spine. That's bad. Third thing is construct planning. I think that's a key. And that's when robotics has really helped me, because now you're being the architect. I'll tell you why. For those of you who put freehand MI screws, all your screws will be like the picture on the right. They'll all be in, but the screw heads may not be lined up, even for the O-arm. But when you use, and when you put the rods in, you're going to struggle. But when you use robotics screws, look at this. This is what you see in the O-arm. But for robotics, the interface, you get an extra panel on the left. And so look at that. The rods will never line up nicely. However, because you know that before the surgery starts, you can adjust the screw heads, and now the rod's going to line up easily, and that's going to be so easy for your CMIS screw introduction. Like this lady. Look, she's got a mild curve, but she's got multi-level stenosis all the way up to the thoracic spine. In this case, what you plan, you can see the robotic planning, is what you get. Look at that. They're almost a mirror image. And because of that, I would say robotic surgery, getting the screws in so nicely with all the planning, drives me to do more MI surgery and gives me the confidence to do so. And you can see 3 days after surgery, she's walking independently. Next thing is the reduction. I think we've all used this for open surgery, the reduction towers. They're really powerful correction devices. But one thing I've learned is that there are 3 scenarios that can happen when you use this. The first one is what we intend to happen. You put that rod down there, which is the red color, and you pull the spine up to the rod, and you got a perfect correction. However, sometimes if the rod, you're using a titanium rod, sometimes the second scenario is that the rod may persuade down or go down to the spine, reduce to the spine. But the worst scenario is actually this: the rod pulls the screws out in patients with osteoporosis, and you really want to avoid this. And how do you avoid this? Because in MI surgery, you cannot see the screw heads, right? And you cannot see how high the rod is. So always look and see this arrow over there. You must understand your reduction tools. If the rod is more than 1 cm away from the screw, make sure you do it sequential reduction. Consider your screw purchase. If you think it's too far apart, recontour the rod. Use the C-arm to make sure you're not pulling it out. And also, understand your rod material. In osteoporotic patients, I tend to use titanium rods. Finally, we all talk about the correct alignment, but when it comes to the crunch, we contour our rods like this. The most rudimentary way, and I think there's a better way to do it, to get our alignment goals, and that's through using unit rods. Last few slides. 76-year-old gentleman with a curve. I put what the unit rods does is you get AI involved to get the desired alignment. So you can see we plan how the rod should be, and the rods is shipped to us, pre-contoured rods, and we fit this plan to the robot so the robot understands the desired plan, and you can see skin incisions is made, reduction towers, and I just want to show you how easy it is to tunnel the rod inside. This is my last slide. So we're using robotic screws to align everything nicely, and unit rods, because the curvature is perfect, that what you plan it to be. And you can see the rod all the way to your left, okay, is the S1, and you can see it's already moving the S1 reduction towers, so I'm all the way through, and now I'm just pushing it further. You can see the rod is sticking on the other end. That's at the eyelet screw. And that little line that you see is where the unit rod tells me T10 has to be as well. So that's how easy it is to tunnel in that rod. And what you see is what you get again. In summary, I'll conclude by saying there are a few tips that I've learned throughout the years for MI's deformity. OLIF has helped me, good patient selection, robotic screws, reduction tools, and unit rods makes it much easier when I do these kind of cases. And I think technology really is a game changer. So thank you, and look forward to seeing you next year.